let's see how many people we've got. We've got a good amount of people here. So
I don't think I have the record option.
let me see.
Yeah. Oh, wait. It says send request.
Try now. You good? I think I okayed your request.
Okay, there we go.
All right, perfect. Thank you everybody for joining us. Sorry for the little late start there. We're just making sure we got all our technical stuff taken care of. Welcome to today's presentation. Today's presentation is on why it is important for individuals 65 and older to receive their pan-respiratory vaccines, with a particular emphasis on COVID, the flu, and RSV. Presenting today is Migrant Clinicians Network's Chief Medical Officer, Dr. Laszlo Medeiros, and from the U.S. Department of Health and Human Services, Region 9 Director, Dr. Jeffrey Reynoso. I want to thank you both for being with us. A reminder to our audience today, if you have any questions at any time during the presentation, please enter them in the chat or the Q&A section. Let's go ahead and go to the next slide, Roxana. Okay. This presentation is being simultaneously interpreted into Spanish. To select either English or Spanish PowerPoint presentations to view, at the very top of your screen, there is a tab labeled View Options. Click on that View Options tab. A drop-down menu will appear where you can select the preferred presentation to view. Likewise, to change the language you are listening to, at the bottom of your screen is in the Zoom toolbar, there is a globe-shaped icon. Click on that icon and select the language you want to listen to. Next slide. Just a reminder that this presentation has been approved by the American Academy of Family Physicians for 1 hour of continuing medical education. And at the bottom of the slides are the requirements that you have to comply with to receive credit. Next slide. To comply with AAFP requirements, I'm going to go ahead and read out loud this disclosure statement. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies, whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. This presentation is in support of the U.S. Department of Health and Human Services Risk Less, Do More Pan-Respiratory Education campaign. No relevant financial relationships were identified for individuals with the ability to control content of the activity. Next slide. All right, I'm going to go ahead and introduce our first presenter, Dr. Laszlo Medeiros, as Chief Medical Officer for Migrant Clinicians Network. Dr. Medeiros is responsible for the oversight of all MCN's clinical activities. Since 1996, Dr. Medeiros has worked in both inpatient and outpatient medicine, in pediatrics, adult medicine, and obstetrics at Keystone Health Center in Chambersburg, Pennsylvania. His work there included treating mobile and agricultural workers as well. He was the Assistant Medical Director at the Keystone Community Health Center from 2001 to 2005. He then joined the new hospitalist program at the Chambersburg and Waynesboro hospitals in South Central Pennsylvania, where he continues his work part-time. Dr. Medeiros also teaches hospital medicine to Penn State, nurse practitioner and physician assistant students and medical residents at Summit Health. Dr. Medeiros, it's great having you here. Thank you so much. And I'm just going to go ahead and let you take it away.
Great. Thank you so much, Martha, and welcome everybody. Good afternoon if you're on the East Coast, and good morning if you're on the West Coast somewhere. It's great to have everybody, and thank you for allowing me to speak. And I know your time is very valuable. I'm going to make this interesting and as helpful as possible for you in regards to what kind of vaccinations we need for our elderly population. So I do work in South Central Pennsylvania, and I have many retirees coming from just south of the border in Maryland, where a lot of the folks come from Washington, Frederick, Baltimore, and they like to retire to Pennsylvania. So we have a large community of 65 and older. I'm going to try to speak slowly here also. I often get very excited about my topic and start to go very quickly. But I'd like to say that my experience with the community of elderly has been over the last 30 years. And I've seen them with a lot of different medical problems, and many of them can be vaccine prevented. I've also worked with migrant workers in our community, and they are some of our more vulnerable populations, as they are often in places where they cannot isolate and cannot do all the things that the CDC often recommends for us to not spread viral infections. So it's very important for them also to be vaccinated. All right, next slide. Okay. So we have objectives, and so these are our objectives at this point, to increase familiarity with 3 key viral illnesses and the vaccines that support respiratory health in those 65 and older. We also increase knowledge about why adults 65 and older are at greater risk for severe respiratory disease, hospitalization, and death. Also, we're going to talk about improving understanding of how chronic illnesses can increase risk for severe outcomes. Martha, I think there's some question about some people not hearing too well. Are we doing okay?
Yeah, we're doing okay. Can someone else confirm that the interpretation, you guys can hear it, is coming in? It might just be this particular individual.
Sound is good over here.
Okay, great. I just want to make sure that, one, I don't talk too fast for our interpreters, as I tend to do sometimes, and two, that everybody's hearing. So excellent.
Thank you, Les. Teodora, it might be your specific connection, so you might need to log out and log back in.
Oh, are we having a hard time with listening to me? Okay, Renee says it's the Spanish version. So let me know if I can't be heard. All right.
And for those of you that are listening in Spanish, you guys can confirm that it's just this particular individual and not everybody that's having issues with the Spanish sound. Thank you. In the meantime, let's move on.
Okay, next slide.
Oh, Les, we have a request for you to get a little closer to your mic, maybe speak a little bit louder.
Okay.
Thank you.
Very good. I'll get a little closer here. Okay, so why should we be concerned about vaccinations among our vulnerable populations? Well, we have a large group of elderly in our communities. Many of them have comorbidities. Even younger people with comorbidities will benefit from vaccination. And also we have immunocompromised younger people who would certainly benefit from vaccinations. Okay, next slide. So some conditions that increase risk for adults over 65. As we know, as we get older, we tend to collect various comorbidities. Some of them we can't help, other ones we can. Some of them are social determinants of health, other ones are genetics. Some of them are behavioral, like smoking. People who smoke will have compromise to their lungs, and this will reach a higher point after age 50, certainly after age 65 and into their 70s. So smoking is one that increases risk of respiratory illnesses for which vaccination would be very helpful. Others are chronic conditions. Again, some people have lung disease, not only from smoking, but from other infections and conditions. And some require supplemental oxygen at home due to COPD and other lung diseases. If they're already vulnerable without being infected by a virus, they have little reserve to maintain their health and fight off viral infections on their own. So vaccinations help these people especially. Again, immunocompromised individuals, some people who have had transplants of organs such as kidneys or heart, they will receive a new kidney, and they'll also receive medications lifelong for not rejecting the new organs that they got in transplant. And so these patients will be using immunocompromising medications that suppress the immune system from rejecting their kidney or their heart or whatever was given to them. Others are elderly and reside together in close quarters, and these are some of our personal care home adults, adult living, extended care facilities, and others that require people to be living in close quarters. And so if one person catches some viral illness, this spreads throughout the community. We did see this in our COVID patients, especially in the last couple of years as well. So these are some of the things that make adults 65 and older have conditions that would surely benefit them having a vaccine rather than experiencing the full blow of the illnesses that we're talking about. Okay, next slide. So we'll talk first about COVID-19. So again, I'm in South Central Pennsylvania. I work as a part-time hospitalist, and over the last 4 years, I have been taking care of COVID-19 patients who are sick enough to be hospitalized, and some who have gone to the intensive care unit, and unfortunately many who have died, especially in the early years before there was a vaccine for COVID in the very beginning of 2021. My group of hospitalist physicians has now seen over 5,500 cases, not quite 6,000 cases, almost 6,000 cases now, and a little more up to date, COVID patients in our community hospital of the 260-bed hospital in the middle of South Central Pennsylvania. So COVID-19 has been around now for 4 years, and it is changing. In the summer of 2024, in the Northern Hemisphere, a new variant took over from what we used to know as JN1, and JN1 went over to KP2, and KP2 has now morphed into KP3 and 3.11. And these are the fastest growing variants in the summer of 2024. Now, luckily, we have advanced our vaccinations, so we are able to cover COVID-19 infections. If you get vaccinated, you still have the possibility of getting sick, but not so sick that you need to be hospitalized by a hospital doctor like me. And so the rate of infection is still more than we had hoped in the original vaccination program, but it still provides so much more protection than going without vaccination altogether. So these are the new variants that are the fastest growing variants as of the summer of 2024. Next slide. Again, why should we be concerned? Well, COVID-19 can give you a very severe respiratory disease. The illness will, for the unvaccinated, often will require supplemental oxygen. In the first years of COVID, we had many people in the hospital on high flow oxygen. And if that didn't work, then we put them on a ventilator with a tube into their trachea and provided breathing for them until the virus ran its course. It was much, much better after the first set of vaccinations came out in 2021, and we had fewer people who were hospitalized and fewer of those who had to go to the intensive care unit and fewer of those that died. So we noticed a big difference once the vaccine was available, especially among those who actually took the vaccine. So hospitalizations and death are still occurring, although at much lower rates now than they had in the past. People who get vaccinated seem to get less of what we now call long COVID. Now, long COVID is a series of illnesses that come 3 months or more after having had COVID. Now, this can happen even if you get vaccinated against COVID, but much, much less so for getting long COVID in vaccinated people than those who are unvaccinated and experience the full disease of COVID-19. We won't talk too much about long COVID here. Unfortunately, there are no biomarkers to tell us who has long COVID or not, but there's a constellation of comorbidities that we as physicians look for to diagnose long COVID. And most of those don't require hospitalization, but they can be very damaging and long lasting. So the concern we have is poor vaccination uptake. So in the last series of vaccinations, the most recent ones, only 20% of adults have had the updated COVID vaccine, and only 37% of nursing home residents have had the updated vaccine. And of care providers at the nursing homes that have updated vaccines, less than 10%. So this is worrisome because the new strains, while they're not as lethal, they are certainly as virulent, if not more so, than the older variants of COVID. So this is concerning. So we'd like to improve the vaccination uptake for COVID-19. Next slide. So you can see here the percent of emergency room visits since October 2022 to June of 2024. And the green, the highest, is among children. Green and red provide us with the under 18 age group. But you can see that also in the purple and the deep blue, we have the over 18, and the dark blue is 65 and older. So you can see that there are the respiratory illnesses come to all of those. The children tend to be doing much better overall, but they do have a large amount of visits to the emergency room, but not as many hospitalizations as the elderly. Now, some of this data is limited. We have, in the last year, had wastewater results. That is the COVID-19 that is shed and gets into our plumbing system and our toilets and into our wastewater. That's been the main marker right now in the last year to see who and where we get COVID in what parts of the country. So it is somewhat limited data. Hospitals are still strained due to COVID and other respiratory illnesses. Currently, we have other viral illnesses competing with COVID, including rhinovirus and parainfluenza and metapneumo. So we have a great deal of other viruses that are out there. And we've seen similar trends both nationally and internationally as what I've seen in our hospital in South Central Pennsylvania. So you can see that there are peaks over time here of hospitalizations or emergency room visits, which often will lead to hospitalizations, especially among the elderly. Next slide. So the updated COVID vaccine is here. The new one for 2024 is available. Question is, should you get it? Why and when? And what about RSV and flu shots? So we'll get into that last question a little bit later, but we'll focus still on COVID-19 here. Next slide. So again, looking at emergency room visits, we saw that the elderly were right up there with the pediatric population. But in terms of death per 100,000 population, you can see that the largest amount here is 75 years and older. And you can see that the amount of deaths over the last year since 2020, the time that we started to recognize COVID, there have been peaks of death that correspond to the peaks of COVID and its COVID variants across the nation. You can see that the younger population there, in yellow and green, are almost flat there after 2022. And so now what we're seeing is since 2023 and on, that it's the older population, 65 to 74 and 75 and older, that are the most deaths. And this is beyond the deaths that just normally we could attribute to heart disease or cancer or other kinds of things that are often happening in older populations. Next slide. Okay, so another thing that we're looking at here, you can see that the deaths and on the last slide and the outbreaks of COVID in these times are showing different peaks, and so we can see that around 9 to 10 peaks since 2020, and you can also see that they're not quite seasonal here. You can have outbreaks, some that happen in the summer, some happen more in the fall. There's a few in the winter, as we kind of expect as people stay inside in the northern hemisphere. But it is not as seasonal as we would like in order to predict, the next outbreak of the next variant. So it is not like the influenza virus, which we predict in the northern hemisphere to come, right around October, November, December, into the winter months of the northern hemisphere. But you can see here that there are significant amounts of daily infection. And there was another peak that rose from our last data point here in July of 2024, so 2 months ago. It did rise a little bit further and is starting to slow down a little bit now as well. And we're seeing less of it in our hospitalized patients as well. So there's some good news there. And at this point, many people have been vaccinated against the older variants, and that will offer some protection. But as I'll go on to discuss here, it's really important to get the updated vaccine as newer variants emerge, and some of our immunity only lasts for a shorter amount of time, especially again among the immunocompromised, because their immune system by definition is not working as well. And so they may need every 4 to 6 months another update vaccine. Next slide, please. So again, COVID-19 is not just like the flu and is not done with us. So as these new variants come and we see these peaks coming at various times, spring, summer, or fall, it is really important to stay up to date. If you did get COVID, then no need to vaccinate right away, because your immune system will have some protection for a few months. But again, if you're elderly or immunocompromised, and for whatever reason your immune system is not working as well as when you were 20 years old, let's say, then it's more important to get the updated vaccine sooner, so that your immune system can learn the new variants, and then you'll be protected for that much longer. Next slide.
As I was gonna wait to field the questions till after, but we actually we received a question that is pretty on point, and if I can just go ahead and ask it.
Sure,
You don't
sure.
mind. The question came
Okay.
in Spanish, so I'm going to translate it in my head and then try to say it in English. The
Okay.
question is from Theodora. She asks, she has heard a doctor say that the COVID-19 updated 2023-2024 vaccine shouldn't be given or taken anymore. That in October, we're going to have the updated 2024-2025. And she asks what you have to say about this, your thoughts.
Right. So there is the new COVID vaccine, the updated 2024 is available in some places now. And so if you have the option to take that, you go ahead and take that. If you don't have it in your community at this point, you can take, if it's available still, in some places that may not be available anymore once the new one has come in. So the most updated one that we have should be the one that we choose if it's available in your community, which should be at this point. But again, I'm looking forward to my colleague on the West Coast also to see, what is available around the country, because I think most of the new COVID vaccine should be available at this time. So if it's not available yet and you're immunocompromised and the old one is available, then go ahead and take what you have. But yeah, the best one to be up to date is to take the new variant, the new COVID vaccine.
Thank you, Les.
Okay, very good. So COVID variants, again, KP3 and KP3 1.1 are the fastest growing variants. And our variants are changing faster and faster, since there are more of them now that they're just kind of budding in different directions. So the JN1 gave more variants, and it's kind of like having children, and then you have grandchildren and great grandchildren. They kind of spread out, and you have like 16, 18 great grandchildren, where you usually have, you don't have those variants breaking out in the first generation, but after several generations, you have more and more variants. And some of them don't cause any illness at all. And then some of them sort of hit the jackpot, so to speak, from the perspective of the virus, and they really do significant damage. So those are the ones that mostly we try to pay attention to as health workers, with the help of like the WHO and the CDC and various departments of health across the nation and across the world. So the new vaccine was developed as these variants emerged, and the emergence of COVID variants are not related to season. I just want to emphasize that again. So it's not like, well, let's wait till October, November when the COVID season really hits. If you have a vaccine that's available now, I think it'd be good to take that what you can get right now. Infections do peak both summer and winter. And again, there have been at least 9 to 10 different waves, depending on how you count them, since 2020. They coincide with various seasons: spring, summer, fall, and winter. So just keep in mind that those are the things that distinguish that from our seasonal flu. Next slide. So the biggest wave yet has been the summer of 2024. Now, they have been very virulent, these variants, and so many more people have gotten them. You can see that spike that I showed you in a previous slide. And yet hospitalizations and ICU, intensive care unit admissions, are lower. And I've seen that in my own work, in my own hospital. We don't have as many hospitalizations, as fortunately this variant is not as lethal as previous ones. However, again, I want to caution that people who do get hospitalized are usually ones who are already on supplemental oxygen because they have some type of lung disease, or because they're immunocompromised thanks to medications that we gave them to prevent them from rejecting their organ transplant, or that they're lifelong smokers and really have very little resistance to any viral infection. So these are the ones that we do see hospitalized. But in general, we have seen much less ICU admission and hospitalizations in the recent months. Again, the newer waves are more contagious, but they seem to be less lethal for most. And most of our data from the last year has been from wastewater, but as starting in November of 2024, hospitals will be required to report COVID-19 cases once again, as we had done in 2021 and 2022. So I hope that our data will be more robust, and we can talk more specifically about the different variants that are in different parts of the country, and not be limited by mostly the wastewater data, which is good, but I think the direct reporting would be much better. And I could better answer, what variants are we seeing in different parts of the country, which, I'd like to get a better answer to that for you, but, I'm blinded by some of the lack of information, unfortunately, that we have right now in our country, because we do not directly report the cases of COVID. So only few hospitals voluntarily will report COVID-19 cases. But as of November 1st, 2024, we'll be all required to report again. Next slide. So COVID and the human immune system. So healthy individuals, it's important to get the vaccine because you try to keep up with the new changing variants. And generally your immunity lasts for 4 to 6 months after the latest COVID vaccine, or after you had the infection. For example, I had COVID in June, and right around now is about the time I'm going to be getting the next COVID vaccine, because I had hopefully some kind of immunity for this many months. And I am also approaching age 65. So if you're 65 and older and or immunocompromised, you suffer the most with the disease recurrence, and often your immunity is even less than 4 to 6 months. If you don't get vaccinated and you get COVID, you have a high risk of long COVID being worse. But even if vaccinated, you may get COVID and get some aspect of long COVID, and generally it seems to be better. But the main benefit, I still believe, is the benefit that the older and more vulnerable populations in our country have against infection and death, because vaccination gives you more protection. Infection, you have to run the course of the disease, and if you're already immunocompromised, it may last longer. It may be more severe form. You may be hospitalized. You may be on a ventilator, and you can die. So you benefit most from being vaccinated if you're 65 and or immunocompromised. Next slide. So long COVID, again, I'm just going to touch on this real briefly. Long COVID, you get less likely if you're vaccinated. You can still get it, but it's usually not as severe. Again, there's no biomarkers for definitive diagnosis of long COVID. So this will be frustrating to us as physicians to not be able to tell our patients that, yes, definitely you have this, but we base it on some symptoms. There are viral fragments that we see that can be detected, and they're more prevalent in tissue in those suffering from long COVID than those who have fully recovered and do not have remnants of COVID. So that is helpful. That's a line of research that I hope to be able to give you more information on that in the years to come. But we don't really have any biomarkers for it. Again, to avoid long COVID, your best chance is to get vaccinated against COVID, especially if you're 65 and older and immunocompromised. Next slide. Okay, so briefly I'm going to talk about influenza. Influenza is seasonal influenza is what we're talking about, which is the H1N1 usually. Just briefly, the H stands for the hemagglutinin surface protein, and the N stands for neuraminidase. And there's a combination there of various types of H's, H1, H2, H3, 4, 5, all the way going up to, I think, H16 now. And usually H1, 2, and 3 are the ones that cause human influenza. Other ones may cause influenza in other mammals, but H1, 2, and 3 cause human. H5 we see in poultry and now in cows. We're not going to talk about that on this talk, but we are preparing at MCN another talk on H5N1. So I won't get into that today. So seasonal influenza is usually H1N1 or H2 or H3. And since there are 9 of the N's as well, you can have all sorts of different variants, which is why, unfortunately, you don't usually have immunity for life from influenza, because each time it reassorts. And so as it reassorts itself, usually traveling from pigs to ducks to cows and back and forth, it reassorts itself in ways that every year there's a new influenza subvariant outbreak. But it's usually seasonal, and it's usually around now that we get that. So we have a vaccination program for influenza. Influenza A is what I just described, but influenza B is also present, and it's already coming to our community in Pennsylvania. Next slide. So influenza A incidence has picked up in the late summer of 2024. It used to be usually October, November, but if you can get the influenza vaccine already, you should get that now. And there's influenza B. Influenza B usually arrives in February, March in the Northern Hemisphere, at least in the Mid-Atlantic states. That's been our experience over many, many years. But it has also arrived a little bit earlier. So the flu shot, the flu vaccine, influenza vaccine, usually available in September in the Northern Hemisphere, and it is available here in Pennsylvania now. And I'm hoping that it's available in many other parts of the country. Again, I'd really love to hear from our colleagues on the West Coast on this. But the influenza vaccine, called the flu vax, is for influenza A and B. And it tries to guess ahead of time which variant of the influenza A will be in this group and which variant of the influenza B. When we get it right, influenza deaths go down that year. When we get it wrong, or there's some kind of other resistance to getting vaccinated, the flu deaths can be very significant. So it's been around for a while, but it's still very serious. Worldwide, there's 290,000 deaths to maybe 500,000 deaths every year from influenza. The worst influenza case was 100 million deaths worldwide in 1918 during what we call the Spanish flu. I hate to call it the Spanish flu because it's not Spanish, but the 1918 to 1920 flu had reverberations for 2 years and killed 100 million people at that time. In recent years, usually if we get the right combination for influenza, 36,000 deaths per year in the United States, but it can go up to 60,000 altogether. So it's much less than what we've seen in the worst years of COVID, but it's still significant, and we have good vaccination against influenza. So, and seasonal influenza vaccine can be given with other vaccines such as RSV and COVID. So again, I know influenza is the one we know the most, but I would not hesitate to get my influenza vaccine every year, especially since I'm also a healthcare worker. I work with patients in the hospital who have influenza or COVID or RSV. And so it's really important for me and other health workers to get vaccinated. Community health workers, the same. Migrant seasonal workers, just the same. And the elderly, 65 and older, immunocompromised, just the same. And the influenza vaccine can be given with other vaccines such as RSV and COVID. Next slide. RSV, I'll go through this briefly. Go ahead, next slide. So respiratory syncytial virus, we thought this was mostly in kids until a few years ago when we started to see it in adults as well, because we started to look. So most RSV infections in adults are not their first infection. This is something that in medical school many, many years ago we were taught as a childhood infection, and many of us in fact did get RSV infections in childhood. So if adults get RSV, it's probably not the first infection that they had. Unfortunately, it does not give lifelong immunity like measles may. So most patients suffer only mild to moderate in clinical disease in general, healthy adults talking about. So most RSV infections have been around before, and you may have some partial immunity from previous RSV infections, but not total. Next slide. So the not so good news, respiratory pathogens often share clinical features of RSV. So it was really hard many years ago to figure out if adults had RSV. We just in the emergency room said, well, you have the common cold and you can go home and chicken soup and rest and some acetaminophen or aspirin or whatever you would take to get rid of the symptoms. So joint aches, runny nose, fevers, headaches, etc. That's often what RSV presents as. And clinical features are insufficient to differentiate between other viral infections. So clinically, it's really hard to diagnose RSV. And certain variants of COVID had loss of smell to help distinguish it. And the newer varieties of COVID, unfortunately, now don't distinguish as easily. So years 2021, 22, if you lost your sense of smell after a viral infection, we said that's probably COVID, not RSV or something else. But more recently now, thanks to COVID, we developed a viral panel, and in the emergency room, we can get this as just a single nasal swab. I guess the ER physicians and nurses were very tired of checking children with one swab for RSV, one for COVID, and one for influenza. So we combine that, and now we can have up 12 to 14 viruses can be tested in a single nasal swab. And this is available in most emergency departments before you're hospitalized. So now I can tell patient, yes, you have RSV, or yes, you have COVID, or yes, you have parainfluenza, metapneumovirus, etc. So that's the real benefit now of being able to say, yes, we have this disease, and you don't have the other one, and so you can be vaccinated against the other one really quickly after you recover from this one. But again, older adults and people with established lung disease may develop severe disease from this RSV. So again, we have vaccinations for this. Next slide. Bad news is seasonal RSV outbreaks in the Northern Hemisphere do occur October to May, the same time as many of the other viral pathogens that happen at the same time, such as influenza. But RSV is the third most common identified viral infection among respiratory viruses requiring hospitalization. So again, you have to take this seriously. We see this in our hospitalized patients, and now we can tell for sure, yes, you have RSV, and yes, you are one of the people that's going to need to be hospitalized. Why? Because often you're more elderly and you have other comorbidities which may make things very bad. In the USA, in 65 and above annually, there are 60,000 to 160,000 hospitalization. 10 to 30% require intensive care admissions, with about 6,000 to 10,000 deaths. So again, I just want to emphasize that RSV is something to be taken seriously. and I see this in our hospital as well. The incidence of RSV-associated hospitalizations increased with age, again, 65 and above, and especially those above 75 years. Next slide. So the really bad news is for older adults with significant comorbidities between February 2022 and May of 23, for hospitalized adults over 60 years, the rate of intensive care unit admissions for RSV topped everything else, 24.3% versus COVID, 17.3%, and influenza, 16.8%. Risk of intubation or death from RSV was 1.39 times higher than for COVID, and twice as high as for influenza. So intubation or death from RSV, this is very significant. So I just want to give you the benefit of, from a physician who does intensive care work, this is what I see in the hospital when RSV season hits. So it is really bad news, and luckily there's a vaccine for this. Next slide. So the RSV available and FDA approved for age 60 and older. I won't go into these in detail here because we're running short on time, but there's a glycoprotein subunit variant, and then there are other variants. In pregnancy, the non-adjuvated vaccine is preferred, and the immunocompromised person, there's a theoretical benefit from the adjuvated subunit vaccine. This will be available in your slides. I don't want to torture the Spanish interpreter and try to get all these names down here, but you have this in English and also in Spanish. So these are the approved RSV vaccines. Next slide. So points of discussion with patients. So help families stay healthy. You live a lot longer, a healthier life if you're vaccinated and don't have chronic conditions that make you sicker and sicker, especially if they are vaccine presentable. Avoid the hospital and medical expenses if you can by getting vaccinated, and you don't have to miss out on work or family events. So I know there's hesitancy because there's multiple vaccines. Again, these 3 vaccines are safe to give at once. I know there's fears of side effects. There's language barriers. There's ideas of I'm healthy, I don't need the vaccine. But as I try to say here, it is important, and using the points that I just made in this discussion, why you need vaccines. And hopefully there'll be availability and access. So I hope I answered that one question adequately. If there's availability and access, take the most recent vaccine for COVID available. RSV vaccine is just once in a lifetime, and influenza is once every year. Next slide. Okay, so really quick, since we work with migrant workers, we have all these vulnerabilities that we know. Migrant workers work in groups. Sometimes they live in group housing. They often do not get the best information. Some of the information is not in a language that they understand, which is why I'm grateful for MCN for making much of this available in Spanish. Living in rural areas, sometimes they don't have access, or they're busy working long shifts and don't get to go to a vaccination program. There's a migratory lifestyle where you move from place to place as a seasonal worker, so you may not get what's available in the place that you are now, and you're about to move somewhere else. There's also lack to healthcare, insurance, or financial resources that our migrant populations don't have, and lack of regulatory protections for much of our farm workers. Crowded housing, as I mentioned, and transportation. So this is what we deal with in Migrant Clinicians Network often here. Okay, next slide. So we do have Q&A, frequently asked questions available at our website. The last one is August 17th. Next slide. So these are some of our resources that we can go over, but you have those on the slides there. So we do have a lot of resources at our website. Please visit our website. Next slide. And there's our availability right there. Connect with our MCN sites. We have comic books with all sorts of different vaccinations, pesticides, diabetes, etc. And we have other virtual trainings. Okay, thank you very much. I think that should do it.
Thank you so much, Dr. Medeiros. And I do have there is one question that came in from Allison. And the question is, excuse me, is it recommended that people who are immunocompromised or over 65 then get a booster every 4 to 6 months, even if they have already had the current vaccine strain, meaning they may get the same vaccine 2 to 3 times before the new vaccine comes up.
Yeah, I'd probably do just one of this current, the most updated one. The older ones are no longer available. The ones we had, the 24 days to 28 days apart in Pfizer and Moderna, the first year, are no longer available. I think the most recent one is the 2023. And so I would just get that one time if the most recent one is not available yet. But I think as soon as the new one is available, the old one will not be available anymore. I don't know if that's true internationally, so I can't answer for that outside the United States. But I believe that the most recent one, when it comes out, the older ones won't be available again. Okay, let's
you,
go to our
Les.
next speaker. I hate to take up more of the time. Thank you.
Thank you. Let's go to the next slide, please, Roxana. All right, and for now, I'm going to introduce our next presenter, who will be talking to us about the Risk Less, Do More vaccination campaign from the Department of Health and Human Services, Dr. Jeffrey Reynoso. Just really quickly, Dr. Reynoso serves as Regional Director at the U.S. Department of Health and Human Services, where he advances the Biden-Harris administration's health and human service priorities. For over a decade, Dr. Reynoso has worked on health equity and social justice issues spanning academia, government, and nonprofit sectors at local, state, and national levels. Most recently, he served as the executive director of the Latino Coalition for a Healthy California, where he was responsible for strategic leadership and external relations, organizational development, and financial management and policy advocacy and programmatic initiatives. Dr. Reynoso, we are so happy to have you here. I'm just going to go ahead and let you take it away.
Great. Thanks for that introduction. Good morning, good afternoon, everyone. And thanks to Migrant Clinicians Network for putting together this webinar. Have a lot of respect for the work that you all do. As you mentioned, in my prior role at the Latino Coalition for Health California, I worked really closely with Xochitl Castañeda, who I know is one of your board members and was also one of my board members. So I'm on family here. I don't want to spend too much time on the intro, but I did want to share why this work is really important. I represent the White House and U.S. HHS Secretary of Health and Human Services, Javier Becerra. He's the first Latino to hold this position in U.S. history, and he often speaks about his father, who worked as a farm worker and as a construction worker. So this work of farm worker health and migrant health is really important to him. I also see here on the line many promotoras, community health workers, health navigators. I just want to thank you for all the work that you do. You all are trusted messengers with your communities, with your families, your friends, and I'm hopeful that the information that I share today from the U.S. Department of Health and Human Services, or HHS, will be really helpful to you in the work that you do every day. Next slide. We at HHS are very excited about the launch of an important public education campaign to help reduce the effects of pan-respiratory viruses have on people in the United States every year. As Dr. Madeiras mentioned, these viruses that we're targeting are the flu, COVID-19, and RSV. And we want to get the word out on how the flu, COVID-19, and RSV vaccines help people risk less severe illness and do more of what they enjoy. We know that for far too many Americans who are unaware of the tremendous benefits of these vaccines, that's why we launched a national campaign called Risk Less, Do More, to inform key communities about the risks of respiratory viruses and empower them to protect themselves from these pan-respiratory viruses. Next slide. Let's level set with some facts, and I'll be really brief here. Flu, COVID-19, and RSV continue to take a heavy toll across the United States. During a 6-month period last fall and winter, these infections together caused 800,000 hospitalizations. More than 10% of the U.S. population last year had the flu, and at the peak of the respiratory illness season, more than 25 2,500 people a week were dying from COVID-19. Next slide. And as the doctor mentioned previously, without immunization, the risk of serious illness from flu, COVID-19, and RSV remains highest in certain populations, including older adults ages 65 and older, as well as older residents who live or reside in long-term care facilities, such as nursing homes. We know caregivers are also important in helping older adults make vaccination decisions. So our campaign will be focused on tailored messaging to caregivers. And, as being a son of immigrants myself, as a Latino, we know how important our culture is as it relates to caregiving, and we often care for our elders. So I'm really excited that this campaign is going to be focusing on caregivers that often serve as the messengers, right, on getting the information out to our seniors and older adults. Additionally, we want to reduce the risk of flu, COVID-19, RSV among communities with a historically higher infection rates and often lower access to healthcare resources. So the Risk Less, Do More campaign has developed tailored messages for adults living in rural areas, Black, African American, and Latino populations, and also pregnant women and pregnant people who can help protect their babies. We also know that healthcare providers are critical trusted messengers with communities, and we will be sharing our resources specifically for healthcare providers or those in the community, such as many on this call. Our campaign also offers healthcare providers those tangible resources that they can share out, print out, and share with their patients and the communities that they serve. Next slide. We are implementing the campaign in 2 stages. We are now, so we started with this first stage of the campaign, which is educating audiences about the RSV vaccine, because we know that this one's a newer vaccine that came to market more recently, and there's lower awareness around that vaccine. We are now in the second stage of the campaign, which is the 2024-2025 flu and the COVID-19 vaccines that have started to become widely available across the country, beginning in mid-September, and should be in most communities across the country. I know that there was a question earlier. The goal is to have them in all communities very soon. So definitely check out vaccines.gov for the most up-to-date information about what is available near you. Very importantly, though, we'll also wanted to share that the campaign is delivering research-based, science-based messages. And this is through paid advertising and media coverage on TV, radio, print, social, digital platforms. So really, we're trying to meet communities where they're at. And I'll come back later on more of that research-based aspect in a couple of slides. Finally, we also want to ensure that audiences have access to the information from sources that they trust. And that's why we're partnering with organizations like Migrant Clinicians Network and many of you on this call, because we know that community often doesn't trust HHS or the government like myself, but they may trust an organization or their healthcare providers or someone that they see every day out in the community. Next slide. The campaign brand, as I mentioned previously, is Risk Less, Do More. And what this does is it emphasizes that some people live with a greater risk of severe illness or death from respiratory viruses. But what's really important is getting this season's updated vaccines to lower their risk so that they can continue doing more of the things that they love. Risk Less, Do More uses uplifting, relatable, and unexpected messages to reach at-risk people and communities and connect them to preventative steps and resources so that they can access that vaccine. Next slide. So here are a few examples of some of our social media ads, and I believe we're going to share a quick video here. Next slide. So as you can see, as you can see, really engaging images that are reflective of diverse communities and with targeted messaging. Next slide.
Apologies for that. Dr. Reynoso, I apologize for this. I tested this prior to the session and I could not get this animation to work. So I will send everyone
it
the
out, yeah.
link so you guys can view it in both English and Spanish. And again, I apologize for that, Dr. Reynoso.
Well, all I'll say here is please go on our website. I'll share more details later on and view the videos. They're really engaging, and please share them on your socials, Facebook, WhatsApp, Instagram. They're full of really great information. Next slide. So, as was mentioned previously, the campaign is creating materials for healthcare providers in English and in Spanish. This includes fact sheets, posters, and social media messages. And we'll be rolling out more assets later on as they become available in the next couple of weeks. Next slide. These are more Spanish ads. Again, very colorful, very engaging. Next slide. And these are some of those materials that I mentioned specifically for providers. So those in clinical settings, hospital settings, so that you share out with your community. Next slide. Okay, so lots of information here, but I'm going to distill it very quickly because I'm seeing that we're close on time. This is more of the details around the campaign. What's really important is that we are now in the middle of that action part of the campaign. The updated COVID-19 flu and RSV vaccines are out in communities across the country. So we're really partnering with organizations at a national level, so state and local health departments, community health centers, community-based organizations, private providers to be able to get the word out and spread the message. So we really need all of us on this call to do this work together. Next slide. What's really important here is, while this is a new campaign, the Risk Less, Do More campaign is new. It's not really new, right? COVID has been around for a couple of years, and we're at HHS and through the CDC, we're building on the lessons learned from prior COVID-19 vaccination campaigns. If all of you remember, I know many of you were involved with the prior campaign, which was called We Can Do This. It was one of the largest health campaigns in US history. And what we learned, there was actually a study that came out in the American Journal of Preventive Medicine that showed that campaign resulted in an estimated $731.9 billion in benefits in averted illness and related costs. So for every dollar spent in the campaign, there was a $90 return on the investment. The campaigns have been science-based, and again, we're building on the lessons learned from the COVID-19 vaccine outreach in prior cycles. Next slide. So this is the most important slide. Last but not least, we have created a web section on hhs.gov for Risk Less, Do More. So that's where you can find all of these videos, social media assets, fact sheets. And we also encourage the community to visit the CDC. So the website is on the slide, cdc.gov/Risk Less, Do More, for the latest information about pan-respiratory illnesses and vaccines. It's going to take all of us working together to ensure our most vulnerable communities have the information they need, get their vaccines, and stay healthy this holiday and winter season. Muchísimas gracias.
Thank you so much, Dr. Reynoso. I didn't see any questions come into the chat. So if you guys have a question, go ahead and enter in the chat or the Q&A, and I can address that. Mariana put in quite a few resources into the chat as well. Please go ahead and check those out. And before we close, I just want to say quickly, please complete the evaluation. We value your opinions enormously at MCN to improve our online educational offerings. Dr. Reynoso, we are going to send out a follow-up email. I guess this comments for everyone. We're going to send out a follow-up email later today. I'm going to be sending it out, where everyone will receive the recordings, both English and Spanish, of this session. the links to the evaluation of both English and Spanish, the PDF of the presentations in both English and Spanish. And then we're also going to be sending you quite a bit of resources, both the ones mentioned by Dr. Medeiros and the ones mentioned by Dr. Reynoso. So again, be looking for that later on today in your inbox, excuse me. And if Dr. Reynoso or Dr. Medeiros, if any of you have any last words to say before we close off, if not, I will go ahead and end the
Okay,
session.
Martha, I just want to thank Dr. Reynoso for complimenting everything I said so well, because there's certain things there, especially you mentioned that the vaccine is coming out, the new vaccine for COVID is coming out in different parts of the country at different rates. And that's one thing I haven't had a great handle on yet as to where things are at. So it's great to have, a companion from the West Coast telling us, what's available, and the government website where it's available. So that's very helpful. And thank you all very much. I know the listeners, you work very hard. I really appreciate it. I especially thank the Spanish interpreters. I try to keep it slow, but I know that's always a challenge. So I do appreciate the Spanish interpretation work. That's really challenging. So thank you all. That's all I have to. Thank you, Dr. Reynoso.
Thank you, MCM, for hosting, and hopefully we can do this again soon.
That'll be wonderful. I'd like to thank everyone for joining us. Again, thank you to Dr. Reynoso and Dr. Medeiros. A very special thank you to our interpreters. We hope we didn't torture you too much. And for everyone joining, please join us again for our next webinars. You check out mcn.org to find out what is coming down the pipeline. Thank you, everybody. Have a great rest of your day.